Welcome to episode number 5 of NeuroCase Forum. I am Dr. Gigy Kuruttukulam, interventional neurologist at Lakeshore Hospital, Kochi, Kerala. 55-year-old housewife was admitted with sudden onset severe headache. Usual story of subarachnoid hemorrhage. CT scan showed diffuse subarachnoid hemorrhage, mainly in the basal cisterns and extending into the sylvian fissure on the left side. Diagnostic angiography and 3D rotational DSA was done. Right carotid angio is normal. Left carotid angiogram was interesting. Along with the carotid artery and its branches, the basilar artery and branches were also visualized. So I did a rotational angio at the level of carotid bifurcation, which showed a branch of external carotid artery continuing as left vertebral artery and basilar artery. This represents a persistent carotid vertebral anastomosis. During early fetal life, anastomotic connections between developing carotid and basilar arterial systems is present. These are named as per the cranial nerves they cause. These arteries normally obliterate before birth. Occasionally, they persist into adult life. Awareness of these variants is important because they can become symptomatic. Aneurysms and other vascular anomalies are more common. The altered hemodynamics can lead to both hemorrhage and ischemic events. Also, this can influence surgical approaches. Fetal origin of posterior cerebral artery is a situation where posterior cerebral arteries are exclusively supplied by the posterior communicating artery. Persistent trigeminal artery is the next. It can be of two types. Type 1, when the entire vertebrobasilar system distal to the anastomosis is supplied by trigeminal artery. Type 2 mainly supplies the bilateral superior cerebellar arteries. Tau sign is the characteristic angiographic appearance of persistent trigeminal artery. Persistent otic artery is the next. Persistent hypoglossal artery follows the hypoglossal canal. Proatlantal intersegmental artery is the lowest of the carotid vertebral anastomosis. Type 1 arises from the internal carotid artery and type 2 from the external carotid artery to the ipsilateral vertebral artery. In this case, the anastomosis is between the external carotid artery to the left vertebral artery, and hence it corresponds to the proatlantal intersegmental artery type 2. No aneurysms or other vascular anomalies were demonstrable in this particular case. So, probably the altered hemodynamics has led to the subarachnoid hemorrhage. Please share your comments and opinions about this case. If you have any interesting neuro case to present as a webcast in NeuroCase Forum, please email the PowerPoint slides and narration to NeuroCaseForum